Hello, and I welcome you to our series on surgical videos. And today we will be discussing a case of posterior polar cataract, as we can see here. And we have planned a Toric Iol for this patient, as this patient has a significant corneal astigmatism. After marking the patient on the slit lamp, we have now marked the axis in which the IOL needs to be implanted inside the eye. This helps in correcting the corneal astigmatism at the time of cataract surgery. Now, the capsular rhexis here is being performed with the help of cystitome. In posterior polar cataracts, the rhexis has to be of adequate size and we should avoid creating a very large rhexis. Now, what I do here is that we use this technique of limited viscodissection, that is very controlled amount of a viscoelastic, a dispersive viscoelastic is being injected instead of hydrodissection under the anterior capsule, and now the hydrodelineation has been performed. So what this viscoelastic does is that it provides resistance and avoids the fluid from inadvertently causing a hydrodissection at the time of hydrodelineation. Therefore, this technique works well in posterior polar cataracts. Now, when it comes to the phacoemulsification, we are trying to rotate the nucleus as less as possible, and we are just gently chopping this soft nucleus. Now, in posterior polar cataracts, as we know that the posterior capsule is very weak, so we need to operate on lower settings. The bottle height, the vacuum parameters, everything needs to be adjusted accordingly. And mostly these cataracts present to us earlier and therefore they are usually soft. Another important tip here is before we come out, we are injecting viscoelastic from the other side port. This is to avoid chamber collapse, which can again cause break in this fragile posterior capsule. Now, to remove the epinucleus, we have injected some viscoelastic behind the epinucleus and then remove this epinucleus with ease after dialing it out of the bag, making sure that we do not cause too much stress on the posterior capsule. Again, before we come out, every time we are injecting viscoelastic from the side port to avoid chamber collapse. Here I am using a bimanual technique of irrigation aspiration to clear out the cortex, and polishing of the capsule should be avoided in these patients. We are now implanting the Toric Iol inside the eye, and after it opens up, we have to place it in the correct orientation, and we have to be a little gentle here, especially in posterior polar cataracts. So I'm just gently nudging this IOL in the bag and avoiding a very rough or a very vigorous rotation. And in the end, we remove all of the viscoelastic, place an air bubble, and that's the end of the surgery. Thank you for watching.